Started?
Yeah, let's do it.
Okay, so welcome everybody to the Cecil Gibbs Research Seminar series at the Research School of Psychology. We've got a really wonderful speaker today. So to start things off, I'm going to hand over to Michaela, and then Connell will be introducing our speaker and managing questions. So Michaela, over to you.
Hi everyone, thank you for joining the Psychology Seminar series. Just a few housekeeping rules. Just a reminder that this seminar is being recorded and will be available on the Psychology YouTube playlist. Questions are welcome and can be asked via the Q&A function or by raising your hand. If raising your hand, you will be invited to unmute yourself and ask your question. Thank you for your attention, and I will now hand off to our theme convener, Connell.
Hi everyone, I'd like everyone just to join me in giving a warm welcome to our speaker today, Professor Grenyer. Professor Grenyer is currently at the University of Wollongong and Director of the Project AIR Strategy for Personality Disorders. Project AIR is an internationally recognised leader in research, education and the treatment of personality disorders. And I really recommend going through their website and looking at all the fantastic material that they have there. Dr. Grenyer is prolific in the field of personality disorders research, and particularly with borderline personality disorder. He's published very widely with over 175 articles, chapters and books. He is also active in clinical practice through Northfields Psychology Clinic and consults widely on patient care issues, including here at the Canberra Health Services. Today, Professor Grenyer will discuss the role of stepped care in the treatment of personality disorder and the results of some recent randomised controlled trials. Given the demand for treatment of personality disorders within the healthcare system, stepped care models have been proposed to manage this demand and provide responsive care to them. So I'd like to thanks everyone for coming along today, and particularly Professor Grenyer, and I'll hand over to you, if that's okay, to take us through this.
Yeah, thank you so much. So I'll just see if I can share my screen here. Is that working for everyone? Is that working?
Yep, that's great, thanks.
Okay, great. And look, I'd like to also pay my respects to the traditional owners. I'm on Darawal country here in Wollongong, but I'm sure that you're in various places across this lovely country, and pay my respects to elders past and present. Also like to acknowledge people with lived experience of personality disorders and their family and carers. Some of what I talk about today, directly comes from the work that we do with people with lived experience, and just acknowledging that much of the research that we've been doing is being co-produced by people with lived experience, but also some of the information that I might present today might be triggering for some people, because we do talk about some rather complex mental health issues, and just to acknowledge that. I'm going to be talking about the approach of Project AIR to thinking about the problem that we have in the treatment of personality disorders, and that is that typically the demand for services outstrips the supply of services. And we've heard a lot about the so-called missing middle, in that is in the sense that we do fairly well in the acute part of mental health treatment. So when people knock on the door of the mental health service, there's somebody there to open it. And we've got good rehabilitation services for severe and chronic disorders. But the group in between, particularly those that fall outside the scope of the better access to psychological services, so tend to 20 sessions who need, for example, a year of psychological therapy or specific groups often find it very hard to source evidence-based care. And that's really one of the things that we've been minded to think about and to address in our in Project Dare. Just a couple of declarations. I don't have any competing interests, except a lot of this work was supported by the New South Wales Ministry of Support of Health, although they didn't have any part in the study design, but they did contribute data. And just to note, our, for the RCT, the approval and trial registration. This is our headquarters here at Wollongong. Although we are based here, we actually do a lot of work across Australia, including in ACT Health. Just acknowledging the large number of people who've worked for Project Dare. And what I'm presenting today really represents the combined efforts of all of these people. Also the people with lived experience who have contributed their expertise and advice to us throughout our journey. And also acknowledging the large number of groups who have helped us to develop the resources and the materials and the things that make Project Dare what it is today. Just a shout out that if you haven't been to a Project Dare conference, we're hoping to do a blended version of our conference this year, depending on the pandemic. The theme this year is creative recovery, and we're really hoping to talk about ways of engaging people with lived experience of personality disorder that's not just talking therapy, but includes other kinds of treatments such as art therapy, drama, play therapy, and other kinds of ways of trying to connect with people's lived experience. We do believe that personality disorders should be a mental health priority area. Sadly, it often gets overlooked. Whenever I talk to people about, well, what training did you get in personality disorders? Often it's like the last chapter in the textbook, or it's the last lecture, if there is a lecture on personality disorders. And I have to say, from my experience and from the experience of quite a few people I talk to, the characteristic of people with personality disorders is quite often a stigmatized, very negative kind of view that comes across in people's fundamental training. And yet at the same time, we know that actually it should be a hopeful and positive description. And one of the big challenges is that not only is it a stigmatized disorder, but it's often stigmatized starting from the very foundations of people's training through to how health professionals talk about people with the disorder. Whereas the view from patients and consumers with lived experience is that they actually want to have the diagnosis, they want to understand it, and that's actually for them a very important part of their recovery. Should also be a priority because we do have good treatments now to treat personality disorder. It's one of the few mental health conditions where psychological therapy is not only the treatment of choice, but is the only evidence-based treatment. So there's no pharmacotherapy that has been established to treat personality dysfunction. We also know it's important because early intervention has a massive opportunity to actually change the transition, the course of treatment for people with personality disorders. If we identify young people with emerging traits and symptoms when they're still at school, we can do a lot to help them not develop the diagnosis. And also families and carers really should be part of the journey and should be part of the recovery and often want to be involved. And traditionally in the past, they have been not only stigmatized, but excluded. We also need better data collection. Sadly, even the most recent National Health and Wellbeing surveys ignore personality disorders, despite it being a really high impact diagnosis in psychiatry, and there being very simple screening measures for personality disorder, it still continues to be overlooked in national surveys, which again, I think is kind of a bit of an indication of how it's stigmatized. The global prevalence is between 6 and 7.8% of the community. We only have very old data from Australia back in 2000, 6.5%, and nothing since. And American estimates are a little higher than the global estimates, but that's around, those figures are relatively, I think, clear that it's around 6.5%. If you want to learn more about Project AIR, that's our website, projectairstrategy.org. We have a lot of resources and materials there. So we have information for people with lived experience. We have information for researchers, for health professionals. We have treatment guidelines. We have videos, lived experience stories. And we have a whole lot of specific information for particular groups. The Project AIR is a strategy, not a research centre or a service. So we actually work alongside services and health practitioners to improve treatment. One of the approaches that we're advocating is stepped care, but we do a lot of things like whole of service training, really work on improving information, stigma reduction, but also really trying to evaluate what we do and create new models of care. One of the things that we are most interested in doing in terms of stepped care is to move people from this side of the screen, the left-hand side, where often people with personality disorders can get stuck between acute crisis, emergency, inpatient, and other services, and try and move them into treatment in the community where they're more likely to get evidence-based care that will be recovery-oriented. And we've done that through implementing gold card clinics that take people away from the crisis teams and start them on the journey of psychological treatment. And I'll talk a little bit about that today. We do have treatment guidelines for personality disorders on our website. And recognizing that people with personality disorders show up throughout the mental health settings, so from GP practices right through to hospitals and schools. So we've tried to cover different ways of those sort of presentations and what to think about. All of our work is informed also by the National Health and Medical Research Council, who published clinical practice guidelines. And they were very influential at the time that they came out because of this key recommendation. It's a legitimate diagnosis for healthcare services. Sadly, the experience of many people in mainstream mental health services is that there's been this kind of ongoing sort of stigmatizing attitude that we don't work with people with personality disorders because there's nothing we can do for them. Or it's not really a legitimate mental health diagnosis. So it's not like schizophrenia or bipolar disorder or depression. You know, it used to be on Access 2. It's no longer on Access 2. There is no Access 2 in DSM, but there's all sorts of ways of trying to say, we don't like these patients and therefore we don't have to deal with them. And so this was a very powerful statement, I think, to say that we need to it's a legitimate diagnosis. We need to provide structured psychological therapies. We shouldn't be using medications. We should be treating people in the community. We should be looking at young people and really trying to be integrative. Personality disorders is a complex disorder in the sense that we all have a personality, but not all of us have had the opportunity to really develop a strong sense of who we are as people and a strong understanding of ourselves in relationship to others. And that can happen because of trauma or other kinds of upbringing issues, attachment insecurities, and a variety of other kind of genetic factors and so forth that really interfere with a development of a healthy self-esteem and a healthy sense of self and a healthy sense of ourselves in relationship to others. And so that personality dysfunction now is understood fundamentally as emanating from disturbances in thinking about self and others in relationship to the self and interpersonal, or the self and other two factors. So people with personality disorders tend to have problems in understanding who am I as a person, and having therefore a real problem in being able to identify where they want to go in life, you know, their life goals and their sense of direction. And that can mean that they have challenges even getting to treatment and recognizing that treatment might be helpful to them because they don't actually understand where they want to go in life. And because they don't really have a strong sense of themselves, they also fail in terms of having what we call a theory of mind, in terms of understanding others. And that can cause problems in them not necessarily having good capacity for intimacy or cooperativeness, or have the capacity to have a complex, integrated representation of other people's minds and be able to see people through their own eyes. So that is the problem we're trying to treat. And psychological therapy works because it helps the people with a diffuse personality to strengthen their sense of who they are and strengthen their understanding of themselves in relationship to others and what makes other people tick. And through psychological talk therapy and skills approaches, people can develop a stronger sense of this is me, this is you, this is where I want to go, and this is how I can understand myself. We've known how to treat personality disorders for the last 30 years, really, and these two key papers were real landmarks. First was Marshall Linehan's first dialectical behaviour therapy study back in 1991. And in 1992, Janine Stevenson and Russell Mears in Sydney published a study on more psychodynamic approach. So both the skills-based dialectical behaviour therapy and the talking psychodynamic approach were really discovered early on to be very helpful for people with these problems. And the field has not really changed all that much. So the last 30 years, we've simply had more studies that have proven that that is still the case. We've had over 33 randomized controlled trials. Again, dialectical behavior therapies and psychodynamic therapies work. We now have different versions of these. So we have MBT or mentalization-based therapies or transference-based therapies. We also have different versions of CBT, and we also have some kind of blended skills and psychodynamic approaches like schema-focused or cognitive analytic. But what we often find, though, is that despite having different kinds of versions of psychotherapy, it's pretty much the same old dodo bird effect happens. And that is that when you put two legitimate psychotherapies head to head in a randomized controlled trial, they almost always come out equivalently effective. So there is no one special psychotherapy to treat personality disorders. And a good example of that is the largest randomized controlled trial that compared dialectical behavior therapy with a simple psychiatric management model that was just once a week individual meetings with a psychotherapist to focus on the person's problems, help them in the here and now, and to help them to understand their emotions and their relationships. And this trial was designed to show that DBT, which was individual therapy and skills-based group therapy plus phone coaching, was going to be superior to just a once-a-week consultation. And the findings were that they were equally effective. And this has led people to really be interested in, well, what is the actual thing we're treating here, and why are different models, you know, CBT versus dynamic models, why they all come out with the same findings? And it's probably because they all share these common characteristics about what we actually need to do to treat personality disorders. So this is my favorite version of the common characteristics: that we need to be structured, we need to help patients assume control of themselves or a sense of agency. We need to help them by being active as therapists, and we need to get supervision ourselves and manage our own countertransference. This is very influential, I think, as a statement for what works, particularly point 2, which is that we need to help patients to really step away from being an external locus of control where, you know, all of their problems were caused by other people, that it's a society that needs to change, and that they're a victim of all of their circumstances and problems, through to recognizing, well, I may not have caused my problems, but I actually need to help myself solve them in the present and into the future, and get onto the recovery journey and be active in that. Once patients move to that kind of sense that they actually are responsible for changing, then psychotherapy tends to go really well, because there's a lot we can help patients with around managing their emotions, understanding themselves, and doing things differently and making different choices. And that often that shift is really the critical one in a person's recovery journey. If you want to learn a whole lot more about personality disorders, I know that there's quite a few students, clinical students and others watching this seminar. We have developed a 5-module online training program. It takes about a day. You get a CPD certificate at the end, and it'll take you through those 5 key factors and talk a lot about how to do good treatment with people with personality disorders. So do have a look at that. Studying lived experience is very humbling. Actually listening to what people who have recovered talk about, what's important to them, and being able to recognize that peer workers are very important. We're doing a pilot right now in ACT Health, where we've got a peer worker and a clinician jointly running recovery groups for people with personality disorders. And they're very powerful, and that's a really new area. But what we find when we do that is that the critical thing about recovery, from being stuck to actually getting into a journey of improvement, is firstly being given the right diagnosis, and secondly, therefore, recognizing that you can actually be active in your recovery, that there's good hope if you stick with your treatment and you work hard at that you can not only improve yourself as a person and your relationships, but you can start to move to things like getting paid work and feeling better about yourself on a day-to-day basis until people become recovered. And there's a lot of people with personality disorder who have gone through those processes who no longer meet the criteria and are functioning really well in the community. We also know that psychotherapy works at a brain and behavior level too. And there's a lot of interest in, I suppose, the neuropsychiatry or neurobiological mechanisms of effective treatment. And some of the really things that actually work a lot is that we move people in terms of their brain activity from the continual pushing of flight and fight responses, which we often see in hypervigilant, emotionally dysregulated patients in the start of their recovery journey, to really being able to start to use their frontal lobes to overcome and dampen down their emotional reactivity, to be more mindful, and to really be able to think through, in what we call wise mind in DBT, ways of being able to approach their problems. We also know it saves a lot of money to do that. So personality disorders, if we treat it well, actually saves the health service a lot of money. It's more cost effective to treat it properly than to not treat it properly, because treatment as usual or ineffective care, which doesn't include psychological treatment, is expensive because hospitalizations and drug therapies don't work, and they tend to be really expensive options that are often given to people. Now, why stepped care? Well, if you actually look at what's the burden of personality disorders on the mental health service, we did this study of prevalence and across 3 years. And we studied basically the whole population in one particular catchment of 270,000 people. And of that, in terms of inpatient and emergency department presentations, one of the largest groups to continuously present were people with personality disorders. Of course, psychotic disorders and mood affective disorders were high as well, but much bigger than self-harm, drug, or others like eating disorders and so forth. So this is like a quarter of your patients coming in to the ED or being admitted to inpatient units have a primary diagnosis of personality disorder. And if we don't treat them well, they tend to come back. So 28 days of discharge, if they come back and represent, that tends to be called a readmission, and it's a problem. And the readmission rate for personality disorders is about the same as it is for psychosis if we don't treat it well. And so that's, again, an additional burden on the health service. And so you can see that the survival curve of people with personality disorders is really quite high. Okay, so we proposed a stepped care model early on as a way of trying to think about how can we manage this large group of patients that are seeking help and need these psychological or based approaches. And we were very minded that stepped care wasn't necessarily new. So back in 2005, it was proposed by Bauer and Gilbody as a way of doing more with less and being efficient with the provision of psychological therapies. It also resonated with our own experience. So we started off by running a year-long DBT program. And the problem we had was, firstly, we had more demand to get into the DBT than we could ever have. So typically we had waiting lists of 6 or 9 or 12 months. Secondly, those who got in didn't stay for the whole 12 months. So they either didn't want or didn't need a whole year of treatment. So there was a lot of wastage. We were offering them a Rolls Royce, but actually they were perfectly happy to get onto a scooter or a briefer therapy that addressed the needs that they had at the time. So the Gold Card Clinic was redesigned as a brief intervention, a 1-month therapy, psychological therapy that took people immediately when they were asking for help. So the goal of the Gold Card Clinics is really to offer an appointment within 1 to 3 days of first presentation to an acute mental health unit or an emergency department, to immediately give the person a gold card that they then take to their first appointment. They get a specific manualized 1-month intervention that starts the process of educating them about personality disorder, helps them to plan for their recovery, does some distress tolerance skills around some of their risks and suicidal problems that they might be having, or real crisis kind of based issues, and start them to think about what's the next step in their recovery journey that doesn't involve going back to hospital and acute care units. To set up one of these Gold Card clinics, it's quite simple. You just need a coordinator to manage the patient flow through. You need a consultant to manage things like medications and reviews, and you need clinicians. We were also lucky enough to be able to do a randomized controlled trial where we had 2 very similar health services separated by a national park. And we simply studied those 2 services as treatment as usual for 18 months. And then we randomly allocated one to start using the stepped care model. And so we had 653 patients, 338 in the stepped care treatment and 315 in the treatment as usual. And we were very interested in the whole of service impact of putting in place a stepped care presentation. What we found was immediately we reduced the demand on hospital services. So people started to be discharged earlier. So whereas before they used to stay in hospital for about 2 weeks, they started being discharged after 4 days because they were given this gold card and they could go immediately to a clinic. They were 1.3 times less likely to represent. So we stopped the revolving door of people with personality disorders continuously coming back. And we saved, consequently, a lot of money and a lot of burden on the acute care services. We were then very interested in, well, what actually happens over that 1 month? Does it actually work, and where is it useful? And we found that actually, like we suspected, a lot of people just needed that 1 month. So half the people who came to us didn't continue after the 1 month of intervention. Either the crisis was resolved, they reconnected with previous supports, or they just didn't come back. Whereas half of them did get referred to private medical or psychological treatment, and only a smaller number, 13%, were actually retained by the publicly funded mental health services, and they typically went on to a DBT program. So the Gold Card Clinic not only helped people get a service, but it also helped to step them up or down depending on where they wanted to go and what was important and how we could triage them into different kinds of programs. We also found that it was a really strong suicide reduction strategy. So people really, if they came in suicidal and really risky, after 1 month of intervention, they were much recovered and less risky in terms of their sense of themselves and their degree of hopelessness and helplessness. They did have some reductions in their symptoms, but clearly some things didn't change a lot. So we still need to have longer term interventions, and recovery needs to be seen as a journey. But having said that, that was a very helpful approach. This idea of stepped care clinics has really been popular. So we've launched over 45 of these now, including, there was one in the ACT. I think it's currently paused, but we've had one there. And now Toronto, Canada is also having one, as well as there being ones across Adelaide and some of Queensland and Victoria. What we've learned is to run one of these successfully, you really need to have strong kind of governance. So we compared clinics that did well, whereas those that fell over. And it shouldn't be of any surprise to any of you that the ones that did best had good leadership and strong clinical governance and a really strong supportive clinician structure that gave them that kind of supervision and manage opportunities to talk about their work so that they felt supported. And we've also implemented the Project Our Academy, and there are members from the ACT Health on the Academy, which is a really opportunity of all of the clinics who have set up these stepped care models to get together 4 times a year now to talk about implementation issues and solve local problems. So that's mostly my presentation. I probably would just pause there to see if there are any questions or comments that you might have about my presentation. Happy to have it by chat or by people want to just jump online. And Connell, you might want to manage that, but I'm happy to take any questions.
Thank you again for that talk. I'll open up to the floor. If there's anyone who would like to ask a question, you could either raise your hand or post something in the chat group. I'll do my best to try and skim through and find any hands that are up.
Is it true that a lot of people online are from the clinical training program? Is that right, Connell?
Yeah, there's people from the clinical training program and the professional training program as well. And I think it's actually quite timely because some students here are going to have their first talk today, first presentation on personality disorders.
Wow, okay, nice.
Timely. If it's okay, I might allow Tegan, if she'd like to talk and give her question.
Yeah, can you hear me?
Have you got a camera taken?
No, I don't have the ability to turn that on. Sorry, Brin, but thank you for your talk. Really found it very interesting. I wanted to ask a question about the role of diagnosis, because I noticed in your model that you said that was often what people identified as central starting point to their recovery. Certainly speaking from anecdotal experience in my clinical work, I've definitely had clients who had previously received a personality diagnosis and found it to be extremely stigmatizing, distressing, and very much rejected that. And I guess I wondered if you could reflect a bit more on when a diagnosis is received appropriately, but also, like, I guess your sample was probably people who felt that diagnosis was appropriate for them. Have you had the experience, I guess, of people who've received those diagnoses inappropriately or in ways that were very unhelpful?
Yeah. It's a really great question and very important. There's actually a paper on exactly this point about people who have had their diagnosis delivered to them in ways that were helpful, and people who have had it delivered to them in ways that were unhelpful. And the trajectory from those two really does make a difference in terms of their recovery. If in our treatment guidelines that I showed you, we actually have scripts for how to give people a diagnosis and how to explain the diagnosis. Typically, what you want to do is you want to say, look, I've asked you about all of these different areas, and you've agreed that this is an issue for you, you've agreed that this is an issue, and you go you show them basically the diagnostic criterion. And then you say, well, look, the good news is we actually understand this as a well-recognized syndrome, and give the name and say, the other good news about it is we actually also understand how to help people with this. And you give them a really hopeful message. And most people who get on board with the idea of working hard on their recovery do well. That's very different from how a lot of people hear their diagnosis. Often they hear it because they see it written in a medical file, or it gets told to them in a way that, you've got personality disorders, we can't do anything about it, or this is just making your treatment difficult. And they don't really have that kind of compassionate, proper explanation. And I think also, if they're working with somebody who doesn't have a psychotherapeutic approach, so mainly sees things through the lens of medications, then it's difficult for them to say, well, this is what your diagnosis is, but actually I can't treat you. And so, there's all sorts of kind of biases there. And so people say, well, I really, really like the diagnosis of bipolar disorder, so I'm going to keep that because that's what my friendly psychiatrist wants me to have. But the sad reality is that leads to more and more treatment that's ineffective, because bipolar medications don't help people with personality disorder, and it won't treat the underlying problem. And so we find that, the international estimates and what we've found is that it can take people about 8 to 10 years between when their symptoms or the syndrome clearly manifests and they actually get the real proper diagnosis. And to us, that's 10 years of wasted kind of problems where they could have been on the recovery journey early.
Yeah, thanks, Brin. That makes a lot of sense. Cheers.
Great, thanks, Tegan. I might just relay a question from Julia, which was, can I ask if you are exploring any online or blended treatment models?
Yes. Yeah, we've got one that we're piloting now. It's an adolescent intervention, so it's partly online and partly therapist delivered. we've also just published a review in that whole area. I can give you the citation probably in the chat. But yes, I think it's a very important area, and the general findings with blended is they tend to work because of the therapist-led component. So people need to have a guide in their recovery, and it doesn't always have to be like a 15-minute session. It can be a 20-minute encouragement. But yes, I think there's a really big scope for more work to be done in that space. I'll send you that citation soon.
Great, thanks for that. I've got another question from Alison. What do you find most rewarding and hopeful about your work in this area?
Well, obviously, when people recover, I think this is. It seems simple to say, but people say, "Look, I was in rock bottom and I was suicidal, and it felt like I was really helpless, hopeless, and stuck." And with the right care, you know, the flower blossoms. Suddenly you have a person who develops a sense of self-esteem. They start to find good things about themselves that they actually like, and they start to do things and make choices that are actually helpful and good for them. And they start to seek out relationships with people who are positive in their lives. And this is exactly why I got into clinical psychology in the first place, you know, to help people live a life worth living. And that is really rewarding.
Great, thanks. And also thanks you for sending through that citation to the chat.
It's open access. So if you click on that link, you'll actually get the article.
Fantastic. I might, if it's okay, hand over to Junwen, who has a question. Junwen?
Yeah, hello. Thank you very much for your talk, and I think it's very interesting. I was interested in the point that you mentioned the theory of mind in personality disorders, and I saw some of the results from meta-analysis in terms of theory of mind in borderline personality disorder. And of course, I think that you know that these people have some impairment in terms of their theory of mind. I just wonder that whether you have any opinions in terms of whether we can use the results of from theory of mind research to apply this to, say, for example, techniques for personality disorders in terms of intervention or treatments.
Yeah. Great question, thank you. Well, one of the therapies that's been manualized more recently is mentalization-based therapy, MBT, and that really, as a target, specifically tries to use techniques to help the person increase their theory of mind. So the therapist's techniques are to use the curious mind or the wondering stance. Can you help me can you explain to me why these things happen to you? Can you think at all about, you know, what choices you might have had at that stage? Can you describe to me how, you know, what went through your mind when you were thinking about this particular behavior or outcome? And can you wonder what it would have been like for the other person, you know, in that interaction, and what do you think was going on for them? All of these kinds of questions, these sort of curious mind or curious, what we call the curious stance as the therapist, are designed to stimulate the patient's mentalization. So to ask for the patient to actually use words to put shape to their impulses, their desires, their goals, their intentions, and for them to, through the process of talking, to discover with the therapist what's important to them and what makes them tick, what are the things that actually they want to do more of, and how for them to better understand how other people may be thinking of them and how they might be able to convey themselves better to others as well. So that hard process of psychological therapy, of talking therapy, is specifically designed to do that. The good news, though, is that even though MBT is designed specifically with a theory of mind kind of basis, DBT and CBT and other kinds of approaches do the same thing, just using different kinds of tools, techniques, experiments, and so forth. So there's a lot of different tools and strategies we can use as therapists to help stimulate and improve people's theory of mind.
Thank you very much.
Great, thanks for that. There's another question that's just come through the question and answer. Vijana, how much of this work has been done on other personality disorders?
Well, that's another great question, because when in 1980, the criteria for personality disorders first came out, there's a whole lot of personality disorders, about 10 personality disorders. 30 years later, there's really only good research on about 3 personality disorders. Borderline personality disorder has about 80 to 85% of all research papers. Antisocial personality disorder, and then there's this kind of like personality disorder not otherwise specified, which is a whole blended mix of others. But there's no randomized controlled trials on any of the others. And in fact, borderline personality disorder is probably like the common cold of personality disorders, in the sense that when you fundamentally look at what is the essence of personality disorders, it's that disorder of self and relationships. And so the ICD-11 now says that there's actually only one disorder, that is a disorder of personality, of which you can describe different features, but there's only one diagnosis. So it's kind of scrapped the 10 personality disorders as separate disorders. The other reason why that was done was because we found, and other people found, that if a person had a personality disorder, they typically had 4 or 5, because there was so much overlap. And that was because they all shared that common underlying disorder of self and other. So I think we've kind of like jumped from all of what we've learned from borderline and now applying that more broadly across people with different kinds of personality traits. But I have to say, I think there's still a lot more that needs to be done over the next 10, 20, 30, 40 years. I mean, one of the highest prevalent subtypes of personality disorder is obsessive compulsive personality. Very rigid, perfectionistic, self-critical personalities, has an overlap with eating disorders and other kinds of problems. There's a lot that we can be doing in that space. So maybe there's some people at ANU that want to take on some thinking around that.
Great, well then I might steal the last question, if that's okay, if there are no other hands up. Because I have a question just around if you're saying the ICD is moving towards kind of one personality disorder, and it also pushes as well to take a non-diagnostic approach. How do you think that then sits with your research suggesting that actually having a diagnosis is really important for people with BPD in that process of recovery?
Well, ICD does have a diagnosis. So it's personality disorder is still a recognized psychiatric diagnosis, defined as mild, moderate, or severe, and being able to be then defined as underlying traits. So it's trying to do both, really. It's trying to have you either have a diagnosis or you don't. But it's also trying to recognize that, like a lot of personality psychology, that we have different blends of different kinds of traits, all of us. And it's only when those traits become really extreme that they might become disordered or a problem, rigid and pervasive and unhelpful. So it's a bit of a debate in the field, and I know that you yourself are doing personality research, Connell, with a lot of scales around some of those factors. And like that research sits us alongside personality disorder research and informs it. In fact, people in the International Society for the Study of Personality Disorders, there's a group that do more of the trait-based personality kind of research, and there's a group that do the clinical diagnosis-based research, but they're increasingly talking to each other, and actually the methods are increasingly being blended together. And I think what we need to achieve really is both a recognition that if health services are based on diagnosis and that's how they get funded, so we can't get rid of that. Patients themselves want to know what their diagnosis is because that helps to inform what they need to do to get well. But at the same time, recognizing that people are complex and personalities are complex, and it can't be just reduced down to little discrete areas where all the complicated blend, and the patient in front of you is the person you treat, not the diagnosis.
Absolutely, thank you for that. And I want to just thank you again for coming in and talking to us today about kind of your research in the area, about the STEP programs and Project AIR more generally as well. Just to, I guess, to wrap up today's talk, and a very timely question by Michael was just, if you had $5 million over the next 10 years to help youth, where would you put it?
Well, I think the issue to me is that most people with personality disorder say that the problems develop when they're at school. So we have a program called Project AIR Schools, where we're working with school counsellors and school welfare staff to identify young people with these emerging problems and to start the journey of them getting compassionate-based psychological care. The risk at the moment is that schools don't understand these problems. Headmasters don't, or principals don't understand them. And the risk is that they get treated as a conduct problem. You know, you need to go home and sort out all your problems, and they get kind of expelled or they have a long suspension. But the problem with that is that people with personality disorders are very rejection sensitive, and they're just trying to understand themselves and to, you know, the best thing that's going to help them is to stay at school and for us to hold them closer to us, not push them further away, and to give them specific ways of helping them understand themselves, to have modified educational pathways that help them to manage their sensitivity or their trauma, and to try and really integrate them better with the supports around, and getting parents and teachers on board with a kind of compassionate approach to their problems. If we could do that, and we're really hoping that we can do more of that, that's where I'd be spending my $5 million, is really working with people on the ground when these kids are showing up with these early problems.
Fantastic. And thank you again for coming in today and talking to us. We'll close up for today. That's okay. And
All right.
we'll see everyone
Thank
next.
you.
Thank you very much.